everybody. Good afternoon and welcome to today's webinar hosted by the Medicines Management team and Let's Make Lemonade. And today we're going to give you an overview of safe systems, pathways and transitions, which is one of the quality statements that forms part of the SAFE key question of the CQC's framework. This is the third webinar now in the series that we've been doing since the start of the year, all with the intention of improving CQC awareness and compliance for providers working in primary care. And so far we've had an overview of the whole SAFE key question, and then last month we covered what's known as learning culture. And both of those are recorded and available for you to watch in your own time. And I'll ask Ben to put the link to the YouTube playlist in the chat in a minute if you'd like to catch up on sessions that you've previously missed. Today, we're hoping for this to be interactive, like always, in the sense that you can use the chat and the Q&A function today in Teams if you have comments or questions that you'd like us to answer. And we'll try our best to have time to answer them live during the webinar, but if not, we'll try and get back to you afterwards. And like the other webinars, this one will be recorded and the recording will be shared with everybody who's registered to attend afterwards, so don't worry too much about taking the notes. For those of you that don't know me, my name is Clare Sieber. I'm a working GP down on the South Coast, and I am the GP Clinical Advisor for Medicines Management team, and I'll be chairing the webinar today. I'll introduce you to the rest of the panel that you'll be hearing from today, whose experience will hopefully give some broad viewpoints on the CQC framework, its impact on us, and the everyday application of it that we need to be doing. So Gary, I'll come to you, and then can you hand over to Mateen, and then Rashad, who will introduce himself and explain a little bit about who the Medicines Management team are. And then finally, we'll come on to Gabby, who will explain who she is and what she does through her company called Let's Make Lemonade. And then Gabby will take us through the content of the webinar.
Thanks, Claire. I think Gary might be Gary's on his way, so he might not be with us.
Oh, okay.
Just yet.
Fine. Well,
I'm sure you can introduce Gary. Yeah, because you know him very well.
I will introduce Gary on his behalf. I'm sure he won't mind. So Gary's a colleague of mine that I've worked with for a few years, and in fact, is a colleague of all of us on the panel today. He's a former practice manager, now does consultancy work for practices and PCNs and federations. He has an interest in leadership and an MBA and some education qualifications, and he runs his own consultancy through a company called Leadership in Practice. And Gabby, later on in the webinar, will fire some practice manager angle questions at him. So you'll hear from him a bit then. Mateen, over to you.
Good afternoon, everyone. Absolute pleasure to be here. Thank you for the introduction, Claire. So just a little bit about myself. So I'm Dr. Mateen Ellahi. I'm a GP partner at Elm Tree Medical Centre, and I've been doing consultancy in primary care around leadership, operational aspects, growing list sizes, etc. I'm also a clinical director and a clinical safety officer, and it's really nice to be here. Thank you.
Thank you. I can't remember who's next. Like, if I go next.
Well, it's come to Rashad next, and move on to the next slide, so we can introduce the Medicines Management team. Rashad.
Hi everybody, lovely to meet you all. My name is Rashad. I'm a pharmacist. I'm an advanced clinical practitioner with many years experience in primary care. I also work as a director of the Medicines Management team, which is an award-winning provider of remote pharmacist and pharmacy technician services to GP practices and PCNs across the UK. Some quick facts about the Medicines Management team before we get into the webinar. Essentially, we're an established provider of pharmacy services for 8 years. We work with around 85 plus PCNs and 250 plus GP practices across the UK. We provide a managed pharmacy service from our remote training hub, fully supervised by GPs and senior pharmacists. We handle all clinical, IT and HR queries in-house. And it's a completely managed service that includes training, auditing, HR, finances, and it's fully within ours. We can get up and going within 2 to 4 weeks. So if you're a GP practice or a PCN looking for some pharmacy spot, get in touch and see how we can help. Over to you, Gabby.
Brilliant, thank you. So we'll just do a very quick introduction to Let's Make Lemonade before we, as everyone said, before we kind of get into the bulk of the webinar. So I'm the founder of Let's Make Lemonade, and I specialise in CQC compliance and inspection and ongoing CQC support. I'm a one-woman band, so it's a very small service, but I have a background in health and social care for about 15 years. And for about just over 4 of those years, I was a CQC inspector down in East London before I moved up north. So I currently offer support around different supports, thinking about mock CQC inspections. I provide ongoing compliance for providers. We offer training and development, registration support, and then looking at action planning, particularly in response to any enforcement that you have received, or if you've had a somewhat negative CQC inspection, then we can help you address the service improvement plans that come as a result of those. So we will just we'll get started now. So safe systems, pathways, and transitions. It's a big one, isn't it? So the CQC have said here that the we is the provider, so it's the aim or the commitments that you have as providers of health and social care services, that we will work with people and our partners to establish and maintain safe systems of care in which safety is managed, monitored and assured. And then we will ensure continuity of care, including when people move between different services. So this I'm really excited about today, because this is actually one of my favourite areas of safety, is looking at the kind of the patient journey and the transitions between multiple different services. Particularly as we go through it, we'll be talking to the rest of the panel and thinking and getting their input on how they consider, kind of mindfully consider and are aware of neighbourhood, local services as well as national services that they're making. So there are 3 pieces of legislation under the Health and Social Care Act that underpin this particular quality statement. The first one is Regulation 12, which hopefully won't come as too much of a shock, because safe care and treatment falls under every of the safe quality statements that we'll be looking at. And there's a particular extract from the legislation here that advises that providers must prevent avoidable harm or risks of harm, and that they have an obligation to assess the risks to people's health and safety during any care and treatment provided. Then we have Regulation 17, which predominantly falls under the well-led key question, but it's rightly so, it's here as well. And there's an extract from this about their care and treatment options. It's really positive to see person-centred care within this particular quality statement, and I know that it does feature throughout the others as well. But you missed that. Essentially, just a very quick recap of the legislation that underpins this particular quality statement. So we're looking at safety, we're looking at good governance, and then we're looking at person-centred care, and reiterating the importance of putting the patient at the forefront of any decisions that we're making. So we've got some information here from the GMC that was published in 2024, and this again joins up quite closely and has been aligned with the assessment framework, which again just brings it home the importance of those 3 particular pieces of legislation and the principles that underpin this quality statement. So the Regulation 9, so GMC, have pointed out that you must promptly share all relevant information about patients, including any reasonable adjustments and communication support with others involved in their care, within and across teams as required. So we're going to talk a little bit about the accessible information standards and how we're considering reasonable adjustments and communicating that with partners as we go on. Then in Regulation 12, the GMC have highlighted that if you assess, diagnose or treat patients, you must work in partnership with them. So the key is partnership with them rather than necessarily other people, to assess their needs and priorities. The investigation or treatment you propose, provide or arrange must be based on this assessment and your clinical judgment about the likely effectiveness of the treatment options. And then we have Regulation 17. This here states that you must take steps to monitor, maintain, develop and improve your performance and the quality of your work, including taking part in any quality assurance and quality improvement practices to promote patient safety across the clinic, across the service. So that information that the GMC have published aligns really nicely with the CQC expectations, and hopefully just brings home kind of the three three key pieces that we're going to focus on today, looking at good governance, looking at safe risk assessments, and looking at how you include and involve the patient in the work that you do. So, like all other webinars that you've been a part of, what we're going to do now is have a quick look at some of the reports that have been published and how they align with some of the requirements that the CQC have stipulated under this particular quality statement. So there are, within this particular quality statement, there are quite a lot of then kind of subsections and bullet points that the CQC have tried to signpost us to and adhere to. So we've tried to just summarize them into three key sections for you. So one of the three of the sections here really focuses on people's care journeys, thinking about how you're going to ensure you have a collaborative and joined up approach, that you're involving not only the people but any other partners in their care along their journey, and that the views of people are listened to and taken into account. And we have two CQC reports, so two independent two GP services that have been rated good this month, and with a particular kind of emphasis on this particular quality statement. So some of the feedback in the CQC report here, we can see test results, referrals and clinical correspondence were managed in a timely manner with cover arrangements during staff absences. Designated administrative staff were responsible for managing and monitoring referrals to ensure people were referred to other services appropriately and were prioritised for urgent actions. So the CQC there are complimenting and praising and celebrating the good governance systems that the service has introduced to ensure continuity of care for patients. And another piece of good feedback was information was shared with the patient's NHS GP where the patient had provided consent. So this is obviously for an independent healthcare provider. Where consent was not given, the service reviewed the information and contacted the patient directly where necessary to ensure any significant or relevant health information was communicated appropriately. So again, that's really important to highlight how the patient was included in their own care journey, thinking about the concept of consent, information sharing, discussing risk, any management plans or ongoing actions that they needed to be aware of, rather than just working in kind of isolation. So in terms of, we can see from those previous reports and those particular elements of the quality statement that thinking about the patient, thinking about reasonable adjustments and understanding their communication needs, their preferences is really, really important. And that aligns quite nicely with something hopefully we all know about the Accessible Information Standard. So this is the exchange of information between medical professionals and patients, and it's central to good decision making. You must give patients the information that they want or need in a way that they can understand. So there are in fact 6 different steps to the AIS concept, the Accessible Information Standard. We'll just run through them now, but for those of you who aren't aware, there is in fact a AIS self-assessment framework available on the NHS website. The guidance within this is really, really comprehensive, and I've done maybe a handful of AIS assessments now with practice managers, with registered managers directly, and it's brought out a huge amount of information for them in terms of looking at gaps in their data, thinking about how they understand who their patients are, what the demographics are, what the communication needs are, and how they can then meet them. So the guidance that's provided outlines a step-by-step process for conducting a self-assessment to ensure that your organisation does meet the AIS requirements. And if anybody wants me to attach the link in the chat, I will. But if you Google AIS self-assessment at NHS, then all the information is readily available there for you. So just some considerations, and these are things that have come up throughout the work that we've done previously. When we're thinking about the 6 steps, so steps 1, 2, 5 and 6 are called identify, record, meet and review. So we encourage you to think about how your IT systems have sufficient functionality to identify, record, flag, share and review information and communication needs. So do you have a clear process for recording people's information and communication needs? And when this is recorded, what's your system for then reviewing it? and what's the use of it? Thinking about interim workarounds. So if, for example, you are relying on paper records, or you've got locum staff in, or you've got agency workers in, or you've got a huge cohort of new patients, how are you gathering this information and making sure that it's being shared across the team, both internally and externally, in a sufficient manner? And step 4, which is meat, would be to think about how well does your organisation ensure that individuals receive information in a format that they can understand, and the information and communication support they need. So questions to think about: do you have a process for sending out correspondence in alternative formats? Do you have a process for producing or obtaining information in alternative formats? And do you have a process for arranging and booking professional communication support, if required? So just some food for thought there for people, which aligns quite nicely with Regulation 9 that we've spoken about. So another part of this particular quality statement focuses on risk, which is the Regulation 12 element that we touched on at the beginning of the webinar. What the CQC here are wanting to see here is that you've got a strong awareness of risks, that you identify and manage these risks, and that the effectiveness of these processes is monitored. So a CQC report recently published where a GP service were given an inadequate rating. The feedback here is that leaders told us it was not the policy or practice to obtain patients' medical history before commencing treatment. Instead, the service relied on information reported by the patient or carer, essentially at the time of the consultation. So I'm just checking the chat. Can everyone else hear? Oh, okay, yeah. The audio is poor. Is it still really poor, everyone? Sorry.
It's fine.
It's coming through fine
okay.
for me, but
Okay.
I'll see what other people put in the chat. But just a reminder for anybody that is struggling, if it's not a tech issue at their end, there will be a recording afterwards that people can, of course, watch in their own time. Looks like it's okay for everyone else, though. Thanks.
Okay, thank you. And then we have another inadequate rating where the practice confirmed that 153 patient paper records, the oldest dating back to July 2025, were waiting to be reviewed and added to the patient's notes on the clinical system. So bear in mind this was published this month, February 26, so we're looking at sort of a seven-month delay in terms of uploading paper records onto the clinical system, which would obviously have a huge impact from a risk management perspective and a clinical decision-making perspective. And a third inadequate rating came with the following feedback: that the provider did not have protocols outlining the treatments offered, their pathways or protocols for risk escalation, and their pathways for protocols for risk escalation. For example, situations where patients must be seen face-to-face. This meant there was no clear guidance for staff to refer to, and although leaders told us that staff would discuss individual cases with clinicians who made final decisions, this process was informal and created a risk of inconsistency. So for those of you who know the CQC well enough, and everybody on the panel, you'll know that those are all some those are some trigger words from a CQC point of view. Having informal processes, having inconsistent systems, having anything that immediately opens the opportunity for risk, not being able to identify what patients need in an accessible or reasonable adjustments or person-centered perspective, all those things are immediately going to contribute to risk. You'll also be familiar, for those of you who have worked with myself and again during these webinars before, about the concept of the 3 Ps and triangulating your evidence. And what you've got here is that although staff are saying that there is some sort of system in place, the processes themselves don't back this up, and the outcomes for patients can't be demonstrated. So that's why the CQC would feel confident, and why that would end up with an inadequate rating, because you've only really got one of the 3 corners of the triangle slightly ticked, I'd say. So just some things to think about. Again, another kind of key piece of legislation that I'm sure everybody's familiar with, but to bring it home and point out how this aligns nicely with the quality statement and with the risks that we've just talked about. The Mental Capacity Act. So here we're thinking that all patients, well, we expect, sorry, all patients have the right to be involved in decisions about their treatment and care and be supported to make informed decisions if they're able to. So you must start from the presumption that all adult patients have the capacity to make decisions about their treatment and care. And then there's just some guidance here about, or some food for thought and some questions about how you can support people to make their own decisions. So questions that you should be asking and that an inspector may be looking further at when they're out on site. So, for example, how have you given information in an alternative format to enable them to make a decision or to be informed about their care and treatment journey and an ongoing treatment plan? Thinking, could anyone else help with communication, such as a family member, a carer, or an advocate? Are there any particular locations where the person may feel more at ease? So, thinking about home visits, maybe community, kind of different places in the community, thinking about whether or not a chaperone would be advisable to support them. Another question could be, could the decision be delayed until they might be better able to understand and make a decision? So these are all things that we'd be looking for from a risk perspective and a safe systems pathways and transitions perspective when out doing inspections. And then last but not least, for this particular quality statement, they are focusing on Regulation 17, which is good governance. So this is about your policies and your processes and making sure they're aligned with key partners who are involved in the people's care journey. So we've got a variety of ratings here. So we've got one service that received a requires improvement rating. The service used a different patient record system to that of the majority of GP services in the locality. This could present a risk to delivering the most effective care and treatment for patients presenting with more complex needs. It might be interesting actually to get maybe Mateen or Clare's thoughts on this, because it's almost as though this provider have been penalised for having an IT system that isn't matching the neighbouring local, neighbouring GP practices, but equally we can understand why the risks have been identified. So we might come back to that one if we get some time. Then we've got here a service that received a rating of good. So the service worked well with people and referred to national guidelines and to establish and maintain safe systems. So very straightforward thinking about person-centred care and aligning it with existing best practice guidelines. Can't go wrong, really. And then another good rating. So the provider met with other agencies and completed shared universal care plans and shared care agreements to enable the delivery of care when patients moved or were treated by different services. And finally, we have a requires improvement rating. So staff told us they used established care and treatment pathways to support the patient journey. And SOPs to support them in their role and improve their patient journey. This one's interesting. I suppose we don't often see staff wanting more policies or procedures or SOPs. Sometimes it's the other way around, where they feel that a service is already quite paper heavy from an operating procedure process point of view. But the fact that staff here are saying that they would benefit from it and they would like it shows that there is probably a gap from a governance point of view that needs to be addressed to give staff that sense of structure, routine and understanding about how to support safe systems pathways and transitions for patients. So that's it. That's a very quick overview of the elements that kind of the subcategories and substatements that fall under this particular quality statement, with a focus on a couple of key pieces of legislation that underpin that and hopefully give people some ideas or some food for thought to make sure that their record keeping, that their staff training, their policies, their procedures, their workplace culture, all of those things are underpinned by existing best practice guidance that sits out there already for us. So we're going to move on to questions now. So we've got a nice amount of time to hear from the panel members. And we're going to start with question number 1 for Gary. So this is with a practice manager hat on. So this quality statement says policies and processes about safety are aligned with key partners. How can a practice manager for a non-clinical team build up those relationships with local partners to ensure joined up thinking, And what are some barriers to this concept?
Hi, Gabby, thank you very much. I hope everybody can hear me. So maybe, yeah, Claire, thank you for the thumbs up. Sorry I was late. So I think the first thing I would say is actually take the time to identify them, because you might not instinctively know them all. I know from my time in practice that was often the case. So I think ask the clinical team, ask your GP partners, ask your PCN, and ask your ICB. Make sure you're identifying them all. And even ask your patients, because I can remember many times where I would be speaking to the patients, find out who they're dealing with, and find out who they're finding helpful and unhelpful as well. And it helps you to list them, to map them. There's plenty of tools and frameworks we can use to map our stakeholders, but it does help to do that, to bring them to life and make it more tangible. So, you know, identify them and then in some way list and map them as well. And then you need to do some work. You need to have some meetings. You need to invite them to the practice, discuss how you can do more working together. But you said about barriers, and there are barriers, and time is an obvious one. But it's always the case as well that a shared goal or purpose is also the same, because I think many times partners start at, you know, different perspectives. So I think having that shared goal, if you haven't got it, it's a barrier. So I'd think about considering asking your PCN or neighbourhood to do this at scale to help with those barriers. It's most likely that neighbouring practices and PCNs are going to be sharing all of these key partners. So do it together to save it being done multiple times. And if you can, I'd consider making it an important event and bringing, you know, everyone together. So there is a reason, so there is a purpose to it. Because as soon as you can identify how everyone working together helps practices, partners and patients, then you're going to find the barriers are easier to get over.
Brilliant, thanks, Gary. Yeah, that's really, really helpful. I think the key things about mapping it and having a visual, you know, a visual oversight of exactly what's going on, but particularly important to lean on the PCN or lean on partners as well, because it, you know, it's not something that can be done in isolation overnight. So yeah, fantastic, thank you. Okay, we've got Mateen now, Dr. Mateen. So this quality statement, this is yeah, I think it's exactly the same question, but from a clinical perspective. So policies and processes about safety are aligned with other key partners. So as a clinician, it'd be good to hear from you. What does this statement mean to you in reality? Is partnership working that straightforward? And can you tell us about a scenario where poor partnership working has contributed to a risk to a patient? And in particular, how was it identified, resolved, and what lessons were learnt?
Yeah, I think this is a really interesting question. I think it actually aligns to the couple of slides before where you mentioned a statement and you said you will come back to it where one practice is using a different IT system to the other. So the example actually is related to it in some context. So I think in reality, the first thing we have to think about is NHS as one system, or are we working in different systems within one system itself, if that makes sense. I think is asking the question whether the system around the patient itself actually behaves like one system. So from a clinician's perspective, I think alignment means any decision that I'm making in general practice, can I trust all the pathways, whether it be community services or, you know, hospital teams, private care, for example, or social care? Am I able to trust that and assume that my decisions are being taken seriously and there's responsibility being acted upon? It sounds simple, but in reality, I don't think it is. I think every organization has its own pressures, their own thresholds, their own IT systems, and sometimes even different escalation guidances as well. So partnership working is less about documents being aligned and more about relationships, communication channels, which we've alluded to recently. The example I want to talk about is actually quite a sad example in some regards. It was actually involving a frail elderly patient who was discharged from hospital with medication changes and a recommended community follow-up. Unfortunately, the discharge letter arrived late, as often sometimes it can happen actually. The medication changes weren't obviously clearly reconciled, and the community services referral hadn't actually been accepted because the patient didn't meet the criteria, even though secondary care had advised for that referral to be done. Now, that all of that wasn't communicated to us, that the referral wasn't accepted either. So from a GP's point of view, sitting in the middle of all of this, we assumed follow-up was happening, but it wasn't. From the hospital side, they assumed the primary care would pick up the referral, and the community team assumed someone else had ownership of all of this. The risk was identified, unfortunately, when the patient deteriorated and was readmitted into hospital. And then the patient was okay in the end. However, looking at that individual case, it triggered a multi-agency review. When we mapped out the pathways of referral, realized the real problem wasn't actually clinical decision making. It was more about accountability, I guess, in some regards, and poor information flow from one organization, let's say, to another, even within a trust, never mind a system like NHS. So the lessons in this scenario are quite clear, in my opinion, is the safety gaps often sit between organization, even within a system, not necessarily within teams often. Assumptions can be quite dangerous. So if, let's say, if in this example's discharge letter needs to be quite clear where it says, we have done the discharge letter, or GP2 action discharge, GP2 action referral, etc. So clear responsibilities need to be designated. And I think then reliable communication systems matter more than policy on paper. So policy can say X, Y, and Z on paper, but if there's no reliable communication systems within organizations, then the policies don't really matter. So since then, we've focused more on direct communication, actually liaising with different organizations in our community, shared protocols, and aligning escalation of pathways. So overall, for me, partnership working isn't straightforward, but when it does work well, it's one of the biggest protective factors for patient safety, and obviously that's quite high in CQC.
Lost sound for a second. Yeah, that's fantastic. Thank you. I think, yeah, one key thing for me that I've probably not considered in enough detail previously, so that's a lesson for me, is about how different services would have different escalation policies and different escalation processes. So you might consider something to be urgent or not urgent or somewhere in between, but actually if the receiver has a different concept or a different understanding, then that's where there can probably, the risks can happen. So yeah, that's something really important, I think, for people to think about, is, and it goes back to what Gary said about building those relationships and professional curiosity and making sure that you are aligning your pathways. Thank you. Okay, Rashad, we've got a question for you from a pharmacist/medicines management perspective. So when a practice employs a pharmacist to support with medicines management, and I'm thinking obviously from your medicines management team perspective that this could be remote or not necessarily based in the same local area that the practice is. How do you get to understand local partnership arrangements in a timely manner, and how does this then inform the role of a pharmacist and the practice that you do?
So how we go about it is we really, at the medicines management team, we tackle it in a systematic manner, so it's all standardized. Essentially, it's all about communication. That's key, really, and working with the practice and not in isolation. So we liaise with the existing staff, understand the teams, the partnerships on the ground, what's available, and then we connect the dots through our staff handover form. Essentially, the staff handover form includes details such as local services available near the practice, the PCN, is there any partnership agreements? For example, in Calderdale, in Halifax, when I used to work there, they had something called the PAIR scheme. So I'm not sure if anyone's heard of this, but it stands for Primary Eye Care Acute Referral Scheme. So essentially, during a medication review, if a patient presents with an eye problem, as an additional problem, the pharmacist can just refer it directly to a local optician on the list, and the optician will see him on the day. And if it's a more complex problem that can't be dealt, they'll just refer it directly to the ophthalmology department. And this really streamlines the patient journey, the process, and it means the patient's getting seen quicker, because otherwise all those clinical problems and the extra problems would just go to the GP, and we don't really want that. So essentially, from my perspective, it's all about being organised, planning, and ensuring really you have structured onboarding, protocols, induction checklists, what are the local services available, and having written practical SOPs. So there's consistency, clear lines of communication, who's the clinical lead, how do you escalate if there's a problem. So that way you're getting one standard way of doing things rather than different partners or GP partners instructing you to do things differently. All about regular communication. That's the most important thing, really. Checking in regular, reviewing risks. Has there been any updates? And one thing that we really like to focus on is focusing on transitions and updates before practices or PCNs notify us, because the NHS is always updating guidance, new PCN targets linked to funding, really. And if we can create the protocols and policies before we're made aware by the practices, we've got a head start, and that way we're working ahead.
Brilliant, thank you. That pair scheme sounds very, very positive. I hope it's still going.
Very helpful, very helpful.
Yeah, definitely. And I think that's a really important example of, you touched on not always having to go back to the GP if there are pathways for other healthcare professionals to be able to make that decision, and have authority and autonomy to do that. Then that's obviously going to streamline processes, isn't it? And it's going to make the patient feel that they are being considered without kind of being sent back and forth. So that's definitely an important consideration of how we maximise, the whole team rather than just the GPs.
Definitely.
So Gary, question for you, practice manager. Not another SOP. Okay, so we can see from one report. Oh, this touches on the feedback from the requires improvement rating that the CQC gave, where staff were asking for an SOP. So we can see one report that staff have provided feedback about wanting SOPs to guide them. So, which I have to say, I don't think I've ever read a report that said that in my life. So what makes a good SOP, and when do they quickly tip into just another document to read?
Well, thanks for giving me this question, Gabby, because I hate SOPs. So this is perfect for me. And I think SOPs are just always another document to read, or as is often the case, another document that just isn't read. But, it's a fact of life that we need SOPs. And for me, the problem and the solution is how they're written and what we do with them. When they're, as is always the case, or all too often the case anyway, when they're just pages and pages of blocks of text, then it's no surprise that nobody reads them, or they don't find them easy to read, or they don't engage with them. So if we produce them in that way and make them too restrictive, then it's always going to be a problem. So I think when they're written, they're ratified, and then they're stuck in a folder or added to this the server. If they're done in the wrong way, then they're always going to be forgotten. And nobody's going to engage with them if it's just an arduous process to go through it. So I think for me, a good SOP is something that's easy to read and easy to refer to. It should be engaging and it should be accurate. And I know that sounds really difficult with SOPs because they're all too often they just aren't engaging, but they should be easy to read, engaging, and obviously accurate as well. And it should be something that's easy to remember and embedded into the way that we work without any additional thought about it. So if you're writing a SOP, and I think even if you've got them, revisit them. Don't just write blocks and blocks of text. Use summaries, use bullets, use diagrams, and anything else that makes it easy to read and engaging. That's a golden rule for them. You should be able to understand it just by scanning it, not having to deliberately read and reread and reread. You should be able to understand it just by scanning it. And then you need to apply it like you believe in it. Teach it at induction. And all the inductions I've had, and probably did as well, I don't know that happens. Teach it an induction, train against it, appraise and measure against it, and check your complaints and your significant events against it. Because SOPs are a pain, but, and I bet I'm not alone on the call here thinking that SOPs are a pain, but all too often it's because we actually do it wrong.
Yes, that's really helpful. Thank you. I think, yeah, for me, the key which you've touched on there is about measuring against them. So it's, you could create, even if you go back and review an SOP now, and you turn it into some really fancy one-page color-coded diagram with images, and it's all looking much more accessible. If it doesn't land with the staff, then it's a wasted exercise. And we know, again, going back to the 3P concept and even that extract from the report from the CQC is enough in itself to show that you have to ask the staff, how is this landing? Do you understand it? Do you get it? Does it work? When you need to follow it, is it accessible? All of these questions, and you've touched on, Gary, thinking about it in supervision, thinking about it in appraisals, picking, we often say have a policy of the month for team meetings, but there's no reason why you can't have a SOP of the month as well. And really, when you are meeting with the whole practice, thinking about, asking for their feedback and their engagement. Otherwise, it is always going to be a wasted exercise. So,
and it's interesting you say let's have a policy or a SOP of the month. Knowing how they're often written, I would roll my eyes at that and think that sounds a horrendous idea. A SOP of the month, how boring. But if you make them engaging, then actually, yeah, I might get on board with the SOP of the month. I still think it's a bit of a hard sell, but
it's a hard sell. Yeah. I think there's no denying that. No one looks forward to the team meeting section where we have to review a policy of the month. But having seen if they're done in a creative way and in an energized way, and actually also reassuring staff that it will be quick as well. So we just need to get through it. We need to understand if there's any key changes. What are the highlights? Yeah. What do you need to do if an incident occurs? Thinking about MCA, complaints, compliments, whatever it is that comes through. What do you need to do? You're putting the Q&A back to the team. Once you, as a practice manager or a registered manager in particular, the registered manager, you have to feel assured that your paperwork is landing. Otherwise, it's.
And if I can give one more thought. I'm talking about making them more engaging. Upload your SOPs to ChatGPT and ask it to rewrite it in a more engaging way. I think you'd get something interesting back.
Yeah, potentially. Yeah, I'd be interested to see some of those. Definitely. Great. Thanks, Gary. Okay, and then last question for Mateen. So they say doctors make the worst patients. Can you tell us about a positive experience in healthcare where you felt confident you're being fully informed about all the options and how this has allowed you to make an informed decision? So this doesn't have to be a personal example. This is more just an example, thinking about the patient journey and putting yourself in their shoes and how they've been communicated with.
Thank you. No, firstly, I just want to jump on the last point. I think I completely agree. As SOPs, I think they need to be audited, right? If they're not audited, this a pointless exercise. And the second thing, I agree with the ChatGPT. Just to be aware, from a clinical safety point of view, no patient data should be on GPT. But I'm sure Gary mentioned that. Okay, so from my point of view, I will give you a personal story. So I'm happy to disclose it. I think I've had a really positive experience as a GP going to a GP for a minor issue, really. And what stood out wasn't the complexity of the technology, it was the communication and the respect given for autonomy. I needed to make a decision about treatments, but all the treatment options were laid out quite clearly, as there weren't any really right answer. And then it was clearly explained to me about the trade-off between benefit, risks, and quality of life factors potentially as well. And I think what the clinician did really well, which I really learned from, essentially was they gave the information assuming without assuming prior knowledge was there, even though they knew I was a doctor. I think they outlined any uncertainty that was present honestly. They asked about the ICE questions, ideas, concerns, expectations, and importantly, they gave me a couple of minutes to think about it as well. So in fact, in the end, I took a week to decide as well. And I think that combination actually created the trust Whether you like it or not, anyone who does give you time and there's shared decision making builds trust. So I left the consultation feeling genuinely a shared decision was made. There was no direction, or there was no, I didn't feel like I was talked to as a doctor. I was talked to as a patient, really, in some regards. And as clinicians, we sometimes think informed consent is about information transfer, and it is in some regards. But I think from the patient side of view, it's much more about feeling heard. It's about actually listening to the patient, respecting them, and them feeling safe that they can ask questions back to the clinician as well. So that experience reinforced what good care looks like. And it isn't just about clinical expertise. It's about communication, clear communication, concise communication, and quality of communication, and making sure that the patient in this regard feels psychologically safe. And I guess interestingly, these same principles apply just as much when we're working with colleagues across organizations, as they do when we're working with doctor-patient contact as well. Thank you.
Fantastic. Thank you. That's yeah, I'm going to have one final reflection, then I will hand over to Claire, who I'm sure will summarise with some food for thought as well. But yeah, I think for me, one of the most exciting things about this webinar series, and this webinar in particular, is I think often when we think about safety, it's seen as something that's a process, and also that it's potentially a clinical or someone in a management position or a leadership position to do to a person. So it's our job to keep somebody safe, or it's our job to manage this risk and to implement this protocol and make sure this SOP is robust. But what I hope people have taken away from today is that actually, if we put staff and if we put patients at the forefront of decision making, obviously, to a degree, because we're not, as a patient, I'm not clinically trained, but do you know what I mean? It's if you include them, and I think Mateen used the word psychological safety, emotional safety, however you want to consider it. And it's the same goes for staff. If they feel included, if they feel supported, if they feel that their knowledge is being, improved and they're learning all the time, then all of those things will contribute to safety in a way that isn't just an SOP, or it isn't just a risk assessment. It isn't just something that's a process that has to be done. It's really, really putting person-centered care at the heart of safety. And I think that's one thing that I do like about this assessment framework, that currently, the CQC assessment framework, is that they do put person-centered care and dignity and respect in a lot of the quality statements across all of their key questions, but particularly safe. And it's just acting as that reminder for us that it goes beyond safe, regulation 12 and 17. So yeah, thanks everybody. That was really good for me. And I'll hand over to Claire now for some thoughts.
Thank you, Gabby. I love the chat about SOPs. Gary, I know you hate SOPs, but I think there verbally what you gave us was an SOP of how to write an SOP.
I hate them, but they're essential. Yeah.
And Ali's made a really good point in the chat. Ali's, for those of you on the call that don't know, Ali does a lot of compliance work as well. And she says that she does a sort of one-page executive summary of each of her SOPs to make them accessible and easy to read and quick to look at for people who don't want to delve into all of the detail, which is another nice idea perhaps to make SOPs slightly more attractive for staff members. Gabby, I'll pick up on the excerpt that you took out of one of the CQC reports about a practice in an area that had a different clinical system to the other practices. Oh, I saw that when I was looking through these slides, and I thought, goodness, that's isn't that a bit punitive? This is a practice that's maybe being a bit trailblazing and innovative and is trying one of the new clinical systems that's out there. So what I was going to do afterwards was put something on LinkedIn for those of you that are on LinkedIn, where I know there's some GPs that are using some of these newer clinical systems lurking, and see what they think of it. But I think the lesson that we have to take from that, whether we agree with it or not, they're clearly thinking about it, the CQC, that if we are using a different system to everybody else on the patch, then dare I say it, we need some sort of risk assessment or some sort of considered thought process that we've had about how we can mitigate any issues in this particular quality statement when it comes to the different clinical system that we've got. Rashad, I had one more question for you. A general question about this quality statement of the systems, pathways and transitions, and how you at the medicines management team, when you're sending pharmacists and pharmacy technicians in remotely to a practice, how you help the practice with its CQC compliance here, and maybe a little bit about discharge summaries as well, because I imagine that's a bulk of what your staff members are doing. They might be processing discharge summaries on behalf of a practice. So any further thoughts for you on how you help practices with this bit when they're commissioning you?
Absolutely. I think discharges is can be a source of problem, especially if you outsource your pharmacy services to a remote provider. All practices and PCNs can assume that you work a certain way. For example, in X practice, when doing medicines reconciliation, it might involve and include medicines reconciliation, read coding, follow-up actions. But in a different practice, they might only want medicines reconciliation from the clinicians. So it's very important to get it right. And if you haven't clarified the SOP, the processes and the expectations from the practice, it can easily lead to errors and safety incidents if your outsourced team or clinician is just making medication changes, but nobody's adding read codes or referring onwards to cardiology. So it's very important that you get it right. I think with us, we've done it for a very long time, around 8 years. So we've built systems, processes that are essentially proactive from our experience and reactive to issues on the ground. So whenever we take on a new practice or a PCN, we get a practice preference form completed just to understand how they like things, how they communicate, how do you request bloods. There's loads of different ways of tackling it, ICE, TQuest. Some practices still use Word documents and their form. How do they do the recall processes, how they handle discharges. All this little nitty gritty stuff is very important to get right. So I think it's just having the processes in place and making sure they're not too lengthy, not 80 pages or 90 pages, because nobody reads it. So you just need a one-page high-level summary that's practical and people will look at, essentially. So how we tackle it is we just simplify everything that comes our way that we can do.
Thanks, Rashad. Lovely. Well, I'll give people some time to put anything in the chat. Oh, Gabby, did you want to come in on that one?
No, just to say that was really insightful. Thank you.
Yeah, it's interesting, isn't it? You can't assume that one practice's request for processing a discharge summary is the same as what another practice is asking you to do when they say process this discharge summary. Yeah, thank you. I'll let people have the opportunity to put stuff in the chat. I thought of some practical things that I think most practices are probably already doing that they can say that they're doing that I think would actually help to tick some of the boxes in this particular quality statement, because who wants to do new things if you've actually got stuff already that can help demonstrate the compliance. So a list of things that I had, for example, and this always gets published in the blog that goes alongside with these webinars, but I think most practices probably have a standard process for acting on discharge summaries and receiving them and doing everything that he's doing with them. So that's a tick. I think most practices track their 2-week wait referrals and probably do safety netting text messages as well when they do them. So that's a tick in that box. Most practices probably have a standard process for receiving and actioning pathology results, out of hours contacts, documents. Again, that's a tip to show that you're thinking about this quality statement. Most practices will have some sort of internal cover arrangement for when somebody goes off to cover their tasks and documents and pathology. Again, that's demonstrating that you're thinking about this quality statement. Lots of us might be using System 1, as do community trusts, and so we can say that we're using an interoperable system and we can task people directly sometimes. Again, tick that we're aware of the pathways and the safe systems. Practices will have some sort of policy for paper records. Sorry, that's my doorbell. Receiving them and summarising them. Again, that's a policy that is relevant for this quality statement, as are triage protocols, your protocols for shared care and system pop-ups and that sort of stuff. Requests from care homes, which are now, for most practices, done through one particular person. that's another good example that can sit under this quality statement. So I hope that gives you some food for thought of stuff that you could already gather and sort of squirrel away under this quality statement that you can reveal should an inspector say, how are you getting on with your safe systems, pathways and transitions?